today's webinar, Trauma Verifications October Q&A Web Conference. Before we get started, I have a few housekeeping items to review with you. There are two options for listening to today's presentation. You have joined listening using your computer speaker system by default. For best sound quality, we recommend switching the phone call in your audio pane and dialing into the telephone number and access code provided. Finally, if you have any technical concerns, please type them into the Q&A pane of your attendee control panel, and I will assist. I would now like to introduce Molly Lozada, Trauma Verification Program Manager.
Thank you. Thank you, everyone, for joining today's web conference. Just want to introduce our team today. It's going to be myself, Molly Lozada, Program Manager for the Trauma Verification, and Rachel Tanchez, who is the Site Visit Coordinator for the program as well. So just going to go over a couple of housekeeping things that we have to go do. So to qualify for CE, you must attend at least 15 minutes of educational content. An email will be sent to all attendees who qualify for CE within 24 hours of the webinar, ending with instructions on how to claim those. If during this entire webinar you have any questions, you may email us at cotvrc@facs.org. The goal for today's webinar is to interpret the standards outlined in the Resources for Optimal Care of the Injured Patient Manual to ensure that hospitals have an understanding of the criteria to provide quality care to the injured patient, understand the processes and standards involved in an ACS trauma verification site visit, and how following these will positively impact the quality of care of the injured patients at your trauma center. So we're going to go ahead and get started. So for anyone who's new to our webinar today, thank you for joining us. And to follow along, please have a copy of the resources manual, or if you have your laptop or your computer, you may also use the PDF copy that's available on the link at the bottom. I will stress how important it is that in conjunction with the book, you must use the clarification document and the verification change log, because if there's any changes to any of the standards that are printed in the manual, they're going to be noted in the change log and also the clarification document. So please have those readily available as well. So again, as I mentioned, the clarification document and the change log are available on the website, on the resources website. Any changes to a standard will be noted on the change log, and any clarifications will be noted on the clarification document. And the web address is in the middle of the page here. And these are just some screenshots on what they look like. Again, the change log, a great tool for any new trauma center that is looking to do a gap analysis. This is an Excel worksheet, and you can filter by level, whether it's a level 3 or level 4 that I've been getting some questions on, but you can definitely filter on this. And I do want to mention that I have not sent out a monthly update for the month of September. We are actually meeting this coming weekend for our annual Clinical Congress conference that is going to take place in San Diego. So there are a couple of things that are on the Verification Review Committee agenda that we are going to be discussing, and based on that discussion and any changes or updates based on some topics, that's going to impact the clarification document or the change log. So I didn't want to send that out and quickly turn around and send another one. So I'm going to hold off on sending one for September until after our Clinical Congress conference. The recordings for the webinars are during the session will be posted within 1 week of the week on the ACS YouTube channel. Again, they are listed on the resources webpage, and the address is noted here. Please scroll towards the bottom of the page. You may end up scrolling a little bit, but they are all the webinars are posted on that page, and they're again towards the bottom of the page. All questions are pulled directly from the questions that were submitted through the portal. There have been no edits made to the content of those questions. If your question is not answered during today's webinar, the question may require more information, and will receive a response from ACS staff within a week following the webinar. We have some announcements. The next webinar will be scheduled for Thursday, November 16th. And the deadline to submit the questions for that webinar will be Friday, November 3rd. And again, our time is going to be from 11 to noon Central Standard Time, so it's a little switch up. So again, that's from 11 to 12 Central Standard Time. And I'm going to go ahead and have Rachel provide the updates for the TQIP conference.
Good afternoon, everyone. So as you all know, the 2017 TQIP Annual Scientific Meeting and Training is just right around the corner on November 11th through the 13th at the Hilton Chicago. Right now, registration is currently open. The guest rooms at the Hilton Hotel are very limited at this time. The Blackstone Hotel still has some available, but is also getting limited as well. And just a reminder, the ACS group rate of $249 is good only through tonight, October 19th. So today's the last day. After tonight, the prices will raise in the rooms. So, and you'll find more information at the link listed there. TQIP pre-conference courses. So the courses listed on the slides are currently open, and all others are closed. So right now, what's open is the AIS 15 update course, which will be Friday on November 10th. And then we have 2 sessions for the bleeding control basics on Friday, November 10th. And then you have the ICD-10 refresher course as well on November 10th, and the trauma registry course, which will be Thursday, November 9th. So be sure to go to the link at the bottom for more information. So right now, these are the only ones that are available.
So I'm going to talk a little bit about the revisions process. Many of you know or have received an email probably from Olivia, who has been sending a call for data for some of our chapters. And we're starting to move quickly on these chapters. So and this is going to be a living link. This public comment website is going to be a living link, so it's going to be available at all times. And so at any point in time, you can definitely provide input on any criteria you want changed or think should be changed or revised or edited or retired, you know, whatever that may be. You can definitely provide your input on this public comment website. So currently, we have Chapter 6 on the agenda for the Executive Committee to approve at Clinical Congress, which is next week. So we're hoping that goes through and that's approved. And then the next one that we are currently working on are Chapter 9, Orthopedic and Pediatric. Pediatric has really taken off, so we are working with the pediatric group in that. Orthopedic just kicked off yesterday, so they're going to start looking at that. And then the call for data for the other chapters has already begun. So again, if anyone has any questions to this process, you can also email us at the COTVRC@facs.org, or you know, provide any input you have on the public comment website. And so again, I will try to provide updates during our monthly webinars on where this process is going to lead us to. So for the time being, even if Chapter 6 gets approved, it doesn't mean it's going to get put out there in the next month or so. It's going to be quite a while before that even becomes real. So, and again, just some highlights, reminders for some resources for new TPMs and TMDs that are new to our process. Frequently asked questions document, again, that's going to expand over time. We're going to build on that. And becoming a verified trauma center tutorial, the first steps. And basically, again, that's just to guide new trauma program managers and trauma medical directors in our process and how to begin that process. So I'm going to go ahead and transfer this over to Rachel for some scheduling reminders. Oh, let me just talk about this real quick. So this is new. If you joined our webinar last month, I did go over this really quickly. So for those of you that are new to today's webinar, again, I just want to talk a little bit about what this is. So Ideally, our goal is going to be that everyone's going to come through a central portal or what we're calling the Trauma Quality Program Participant Hub. So everyone will go through there. Everyone will have a login where they can apply for a site visit, or if you're a new center, you can request a new site visit as well. So basically, it's a new Trauma Quality Program Participation Hub and Account Center. That's what it's being called. And this is your new point of access for participation in any of our trauma quality programs, that being TQIP or verification. You can access the account center to manage your facility and contact updates. So if there's been a change in your trauma program managers or trauma medical director, or even your CEO, which happens more often than not, because by the time you submit your site visit application, you're looking at a 12-month window, and by the time I release the letter and the report, there may have been some staff changes, and I'm unaware of that unless I receive an email or somebody on our team receives an email and updates our database. So just keep that in mind, that this is a great place now that you can manage your facility and contact information, and again, also to request a site visit if desired. TQIP participants will also be able to access the TQIP training materials from the Account Center. To get started, please view the Account Center tutorials located in the Training Resources section of the Participant Hub. And feel free to email traumaquality@facs.org with any questions, or you can even email the COTVRC at FACS, and we'll be sure to direct your questions to that team member. So thank you.
Okay, so site visit applications. So we are still asking that your site visit application be received in our office 13 to 14 months before your site visit. This will give you plenty of time to prepare for the visit and to complete your online PRQ. Plus, this also holds your spots for the visit. At this time, we are completely booked all the way through October 2018. There are still spots available for November and December of 2018.
So there's a couple of things that need to come along with your application if you're a level 1 trauma center, and that's the Orthopedic Traumatologist Leader Form. I think I mentioned last month that we have kind of gathered a lot of data in the last year for these trauma centers that have an OTL approved leader, and so we may have your orthopedic leader on that form, or on that spreadsheet. So if you have any questions about that, you can definitely contact us at COTVRC@FACS.org, and we'll have Anita contact you if they need any other information. But in the meantime, for level 1 trauma centers, including pediatric trauma centers and combined level 1 trauma centers, we do want you to fill out that form and submit that with your application, because there's a process that goes along with that gets reviewed by our orthopedic subcommittee. And the other thing we also want on the form is the alternate pathway. If you have any trauma surgeons or emergency physicians who are not U.S. boarded, meaning they've trained overseas and are not boarded here in the United States or in Canada, they will need to follow the alternate pathway criteria. There's a document on the webpage that tells you what criteria they'll need to follow leading up to a site visit. But I do want to mention that this is not applicable to those that trained here in the United States and just for whatever reason never became boarded. They cannot apply for this. And I think in one of these slides I will talk about what that process entails if they've gone through the process before.
Okay, so your pre-review questionnaire, online access. When your application is received in our office, you'll get an email receipt, and your PRQ logins will be in the context of that email. The online PRQ can be accessed at the link, and also a copy of the PRQ in Word can be downloaded from the link listed on the slide.
Can I also add here, for those trauma centers, again, that are not familiar with the online PRQ, the Word copy is a great tool because it is the same that's online. You just got to be sure you're downloading the appropriate one because it is by level and patient type. So again, we're looking for the patient type that were admitted during the reporting year. So if you're a level 1 trauma center seeking verification, you may be just a trauma center that just admits adults, but you may also be a level 1 trauma center that admits adult and pediatric, or children rather, and you want to make sure you download that because there are some tables you'll need to complete for pediatric. So again, just be aware of the type that will be downloaded and also the type of online PRQ you're going to be completing.
Okay, so site visit application payment. We ask that you please do not submit payment with your application because your center will receive an invoice approximately 60 days before your scheduled site visit. This will include the annual fee for re-verification and TQIP. The annual fee does not include fees for additional reviewers if needed. At the link below, there's a great fee structure with the fees for the next 3 years. We encourage you to view it. So scheduling the site visits. You should receive your site visit confirmation email by at least 90 days before your scheduled visit, give or take. And ideally, all visits will occur during your requested time frame. As a lead reviewer is available for your site visit, you'll first contact the trauma program manager to confirm the dates prior to finalizing the visit. We strive to get you your dates much earlier than before you receive your confirmation email, so you and your team can prepare accordingly. Now, with all that said, I just wanted to let you know, we are piloting a new scheduling process, and again, this is just a trial. So you should have received an email from me probably within the last week, and that's for those who are going to have a site visit in April, May, and June, which is the second quarter of 2018. And what we are asking is for you to give us specific dates that you would like to have it on. And we're hoping that this will help us to not have so much back and forth with emails so that we can just get these scheduled and get you your confirmation email a lot earlier than the 90 days. So site visit preparation with the reviewers. So reviewers will book their own flights through the ACS travel agent, and they do this approximately like 30 or 20 days prior to the visit. The hospital is responsible for the site reviewers' hotel accommodations as well as their ground transportation. The reviewer's contact information will be provided in the confirmation email once the full team has been secured, again, approximately 90 days before the visit. And also, please be sure to contact the reviewers directly within 30 days of the site visit. And this is to basically email their hotel confirmations, get their flight itineraries, just like coordinating any ground transportation to and from the airport, and any other site visit logistics.
So we're going to go ahead and move on with general questions. So I had a question about combined level 2 and level 2 pediatric trauma centers. So they're asking, does the center have to have separate policies, guidelines for everything, meaning the MTP, ortho schedules, etc.? So no, the answer is for combined trauma centers, level 2 pediatric trauma centers, and with the level 1 or level 2 adult center may share the same protocols, policy guidelines, as long as language speaks to both types of patients. So that's acceptable. Trauma surgeon oversight. Question is, surgeons want to know how long they must follow a patient if the patient has a single system injury. For example, the patient has an epidural bleed, and the patient met step-down activation criteria. How long must the general trauma surgeon follow the patient if there are no other apparent injuries? Is there a set time period the ACS states they must follow the patient, or can the surgeon sign off after 24 hours? So there's not a set criterion for the length of time the attending must follow the patient. However, the expectation, and this is for any trauma center level, is that the attending oversees the care for the patient while under their supervision or their care. Once the patient is handed over or signed off to another service, say orthopedics or an intensivist or the hospitalist, the trauma surgeon attending or the trauma attending no longer has oversight of that patient. So that's acceptable. During the recent optimal course back in April in Module 3 regarding PIPs and the registry data, a clarification between missed injury and delayed diagnosis was provided. However, upon return to my facility, I was unable to locate supporting documentation of this clarification within the clarification document and the verification change log or the NTDS data dictionary. Historically, these critiques have been internally defined within our facility as delayed diagnosis, any injury identified from 24 to 72 hours from presentation during hospitalization, or 2, missed injury, any injury identified greater than 72 hours from presentation or after time of discharge. So these clarification definitions from the optimal course have to be adopted by our program. 1, delayed diagnosis, and second is missed injury. So the short answer is no. They don't have to be adopted by your trauma program. Basically, and again, let me just say this. So the person who submitted this question, it will not be found in the clarification or change log. The missed injury diagnosis from the optimal course were examples of the types of injuries that should be monitored through the PIPS program at your facility. So again, it's not a requirement. It's not anything we're asking you to adopt. The optimal course, what they did is they just provided typical data fields for a trauma center that, you know, usually there are issues with these types of things. So again, if your trauma centers is identifying those from 24 to 72 hours, that's fine if that's what your policy is. So those were just examples from that course. Alternate pathway previously approved. So this is where I spoke to a little bit before that there was a slide on this. So although this question was discussed, please clarify if possible. If you have a non-boarded U.S. trained physician was previously provided alternate pathway by being current in ATLS, attending in-house trauma meetings, will they be grandfathered in? Yes. So they will be grandfathered in terms of that surgeon, whether it's a surgeon or an ED provider, has previously been approved through the alternate pathway at your facility. If they have been approved at your facility, we still want to know their name on the site, this application. This physician will not need to be re-reviewed, if you will, during the preceding visit. So basically, they are going to be held accountable to the same standards as everyone else on your trauma panel or who's taking trauma call. So that would be meeting CME, whether external, internal, or through an internal education process, OPPE review, peer review attendance if they're a trauma surgeon. And the one thing that they will be held differently, if you will, from any of the other members is that their PI assessment by the trauma medical director to ensure patient outcomes compare favorably to other members of the trauma call panel. And this is one of the criteria that is stipulated in the alternate pathway criteria guidelines. So this is the one thing that if you have a surgeon that's gone through this process before and they were approved, this is the one thing that we're gonna review at every subsequent site visit. So the surgeon will be grandfathered at your institution. So what I don't have on here is if your surgeon or provider or physician moved from your facility and moved to another center, whether that's across the street or a sister hospital or across state lines, they have to repeat the process. Again, here's another alternate pathway non-approved surgeon. So I was a little worried about this slide. So if the person is on this webinar and I did not answer your question, please reach out to me. Question is, we have a non-US boarded NSR, which I'm assuming is neurosurgeon, at a level 1 verified trauma center for 15 years. Is he grandfathered or has to do alternate pathway? So I had a couple of concerns with this. So based on the information provided here, I take NSR to mean that it's a neurosurgeon. If that's correct, And if the neurosurgeon is taking trauma call, meaning they're seeing trauma patients and assume the role functions as a neurosurgeon, they must have gone through the alternate pathway criteria at some point in time, I would think. If not, if the neurosurgeon did not go through the alternate pathway process, then my question would be, what is his or her role on the trauma service, and why has the surgeon not gone through the alternate pathway criteria process if they've been at an ACS verified level 1 trauma center for 15 years? So again, I probably will follow up with this person, but I guess I would be concerned as to they've been there that long and they've been, this has been a verified trauma center. So either this person's gone through the process before or needs to go through the process at the next subsequent site visit. Question about ICU panelists and CME in the PRQ. So there's a question in the PRQ that asks ICU panelists, non-liaison, in regard to trauma call, what do we mean by that? Is it the trauma surgeons or the critical care docs? So to clarify, it's question 16 is regarding peer review attendance, and question 18 is regarding CME for the ICU panelists. So I just want to make sure I was clear on that. And to answer this question, ICU panelists are the ICU physicians, not the trauma surgeons, that provide care for the trauma surgeons while in the ICU. So that's what that question is alluding to. PRQ OTA leader leaving institution. I thought this was a great question. I know we've talked about folks who've left the institution and are no longer there during a site visit. We have an orthopedic surgeon that we completed the OTA form for, and he leaves the institution 2 months prior to the site survey. Do we submit another OTA form before the survey for another orthopedist? Absolutely. If you have not done this already, please do so as soon as possible. As I mentioned before, the form has to go through a review process by our orthopedic committee. So we do want you to submit another form with the new OTA leader, and we do want that information updated prior to the site visit. You know, anything we can do leading up to the site visit is better than having it cited as a deficiency during the site visit and you know, possibly creating some challenges there for the reviewers and the trauma center. So, so again, please submit that to us as soon as possible if you have not done so yet. PRQ listing prior deficiencies and weaknesses. We get this quite a bit. In the PRQ, when it asks about last survey dates, weaknesses, and deficiencies, should a state site visit be included? No. Do not include your state process in the PRQ. What we're asking for is any previous verification site visits performed by the college. So if you did not have any, if this is your first site visit by the college and your state possibly came out and did something for you, don't just leave it blank. Don't put anything in there. So we're going to go ahead and move on to CD related questions. Question about transfers out. My trauma medical director wants clarity if PD trauma admitted, transferred, or died are reviewed or just admitted to our level 3. Based on the short question, I'm basing my response on that. So whether the trauma center admits pediatric patients or they are transferred to an appropriate verified trauma center, those cases must be reviewed through the PIPS process. So that is a requirement, CD 4-3. So for this trauma center, if they're going to get transferred, they should be reviewed. There may be times when the trauma surgeon should become involved if there is an injury that needs dealing with or there is a delay or difficulty transferring the patient. That's that's in reference to whether or not your trauma surgeon needs to be involved, and they do. Again, and if they're transferred or if they died, you also want to look at those through your PIPS process. There is a, I don't know the CD off the top of my head right now, but there is a CD about reviewing your deaths. OPPE, do trauma APPs need annual OPPEs? If yes, must these OPPEs be completed by the trauma medical director, or would it be permissible for another trauma surgeon who is also the SICU director to complete the OPPE? So I know we've talked about this at length. If the APPs are involved in the initial evaluation of the trauma patient, they would need to receive an annual OPPE. And I do want to clarify, if these APPs are serving under the trauma service, then that would be under the direction of the trauma medical director to do their annual assessment. And if their APPs are under the service of, say, the emergency department, then it would be under their respective director. Again, if they're advanced practice providers from ortho and neuro, you want to have their annual assessment done by their directors. So the TMD is not expected to complete those evaluations personally. However, they should have some insight as to how those are done or what those guidelines are. Non-surgical emissions, our admit to non-surgical service remains over 10%. We do complete PIPS review on all cases. We are in jeopardy of a deficiency. No, they're not. For this trauma center who has greater than 10% and do a PIPS review on all your cases, you're not. You're doing exactly what the requirement asks you to do. And I do want to clarify, having non-surgical admissions in excess of 10% is not a deficiency on its own, provided that the facility completes a PIPS process in all cases, meaning that if you do have an excess of 10%, say 30%, we've seen them as high as 50%, seriously, and you are doing a PIPS review on all those cases, then you're doing exactly what the requirement's asking you. The deficiency will result in is if you are not reviewing your cases through your PIPS process for appropriateness of care. So that's where the CD will lie. Transfers out for orthopedic. Can a level 1 pediatric can a level 1 pediatric trauma center transfer orthopedic patients to a level 2 pediatric trauma center if the ortho traumatologist is unavailable? So I had a little concern with this, again, because it's a level 1, and I wouldn't know why a level 1 would be transferring a patient to a level 2, since a level 1 has to have all the resources, same with a level 2. So if the person is on this webinar, I may have some follow-up questions for you. I think, and maybe I'm misinterpreting this, but if the question is alluding to that the level 1 has to have the OTA orthopedic member be the one on call at all times, that is not the requirement. They do not have to be involved in the care of all the injury trauma patients. I would highly recommend the center reviewing the instances where these transfers are occurring and why they are occurring. So again, a level 1 should not be transferring to a level 2 unless there's a reason that they have a specialist that is only at the level 2 that they can manage that type of injury if it's a complex injury, and you would have to have a transfer agreement. But again, I would just be looking at these occurrences. Orthopedic trauma backup schedule. Does a level 2 program need a backup orthopedic call schedule? My orthopedic surgeon only takes call at one facility. A level 1 and 2 trauma center must have either, there's a choice, you can have either dedicated orthopedic surgeons at your institution or have a published backup call schedule if they're not dedicated. So in this instance, if your orthopedic surgeon is dedicated to your institution, a published backup call schedule is not required. Page 67 of the Orange Book, child maltreatment assessment capability. Does that mean a child abuse pediatrician available? Does that mean that a child abuse pediatrician has to be available 24/7? No, it does not. It refers to having a mechanism in place to assess the maltreatment in children. This may be accomplished by having guidelines, protocols for screening, treatment, and referral for children injured as a result of maltreatment. All patients who have an acute injury as a reason for hospital admission should, not must, should be assessed by the trauma team and admitted to the appropriate surgical service. CME pediatric combined centers. So level 1 adult, level 2 CD 1029, is there a minimum number of hours for pediatric anesthesia and radiology provided by the pediatric specialist in their specialty, or is it at the PD specialist discretion? So to clarify, there are no CME requirements for the anesthesia and radiology providers. That includes their liaisons. So there are no requirements at this time for them to have CME. However, there must be a specialty-specific pediatric education made available by the pediatric specialist at their discretion. So meaning if there's an issue that was found, or is there a weakness or something that needs to be improved during radiology procedure or anesthesia, they have at their discretion to provide education to the other members of the trauma call panel. Radiologist response for interpretation intervention. CD 1133 must be available within 30 minutes to perform IR procedure. Is this from time of call to start of procedure? How are institutions meeting this? In-house 24-hour IR physician. This is a level 1 trauma center. I thought this was a great question. So let me answer the first question, the 30-minute response. So that is from the time of call to request the service. It is not from the time of procedure or incision. So it's just from the time that the attending is making a call to have that service perform it. So how some centers are doing this is they have qualified radiologists or vascular surgeons that are trained to perform IR procedures. So if you have a vascular surgeon, I think there may have been another specialist, and I don't have it on here, but there may be other ways to do this. And then there's some instances, if it's a level 1 and the center has credentialed fellows to independently perform an angiogram or embolization, or at least to start it, then they can qualify for the 30-minute rule, just not do it independently. So there's a few ways to manage that for a level 1. ICU emergency for level 3 facility, can you clarify the requirements for ICU? In level 3 trauma centers, physician coverage of the ICU must be available within 30 minutes with a formal plan in place for emergency coverage. 30 minutes from when? The decision to admit, patient arrival. So I wasn't really 100% clear where on the decision to admit or patient arrival. So I may have to follow up with this person, or this person can follow up with me if they're on this call. To clarify, the 30-minute response is for when the trauma patient is in the ICU and there is an emergency. So I hope that answers the decision to admit. So the clock begins when the call is made to the credentialed provider, and that could be an ED physician as a backup if the attending is not available. What are the requirements per ACS for trauma registrar education? I'm not looking for the number of hours required, but what is the regulatory body that would approve of the content for this education? So this is noted in the book. The registrars must attend or have previously attended 2 courses. So the 2 courses and within 12 months are the American Trauma Society's Trauma Registrar course or equivalent provided by a state trauma program, and 2, the Association of the Advancement of Automotive Medicine's Injury Scaling course. So those are the 2 that are noted. There are some equivalent programs out there that we actually ask if a center is going to use an equivalent program to ask us, myself rather, if you can submit an agenda or a curriculum of that, so we can ensure that it does meet the same objectives as the ATS and the AAAM IS courses, the administration or learning sequence and format. So we want to look at those curriculums if they're going to be something different than what these 2 are noted in the book. So a couple of questions about loop closure, or I should say this one about loop closure. Are there specific details or requirements that the surveyors will be using in order to determine proper loop closure for PI? So I know this comes up a lot, and I think that this is it's variable. It varies based on trauma centers, and ideally what the trauma surgeon is looking for, or when they go and they're looking at loop closure, the steps that they usually look at is, for the trauma center, is, was there a PI issue in the care of the patient? And then what they do is they drill down. They'll go down, they'll say, did the program identify during the PI process? Or did they identify it at some point during, not necessarily during the PI process, but at some point? If so, the reviewer wants to know or wants to see the records. It's important to document that and not have it done as verbally or in a conversation down a hall. It has to be documented. If that was not done, the center, be honest with the reviewer, tell them why it wasn't caught during the PI process, and you can tell them how it's going to change, or if you see something similar to this. And you want to tell them why it was important or it was important. The question would be, excuse me, for the reviewers is, show me the PI on a case. It's best to expect that it's a problem, that this is a problem, and have the PI records attached to that chart. So if you're in your review period and you're going to pull cases and you're going to pull PI, you want to make sure that the PI, if there was any PI for that matter, attach that to the case or the medical record, or flag it for the reviewers if you have an electronic PI record. This will show that your program has a tight PI process. Also, the reviewers will want to see how the problem was found. Was it during routine auditing, through a report? Did your PI nurse catch it, or a nurse catch it, or anyone who caught an issue? Was it through a patient complaint? Anything like that. You want to document that. What was the initial investigation consisted of, who that was presented to, and what the recommendations were, and the corrective action and closure. So again, you just want to make sure that you're documenting this, you're capturing it, you're documenting it, you have a corrective action plan, etc. One of the things that one of my reviewers recommended is having a spreadsheet that you have columns, and you have a column that says corrective action plan and responsible person and evidence of loop closure, or something along those lines. And this way you can actually present that to the reviewers if there was a problem found or there wasn't a problem found. So I didn't want to spend too much time on this, but I probably can provide more details in an email if anyone's interested in this. Universal screening for alcohol is a level 2 trauma center required to screen all injured patients for drugs of abuse. So basically right now what we're asking is for a level 1 and 2 trauma center to do universal screening for alcohol must be performed for all injured patients that meet NTDS inclusion criteria with a hospital stay of greater than 24 hours, of which 80% must receive a screening. I said yes to this because I don't know if you would be able to tell a difference between drug versus alcohol. I'm sure you can, but I don't see why there would be any difference to doing a screening on those types of patients. This is regarding pediatric patients. With regard to universal screening for alcohol for pediatric patients who are less than 15 years of age, is there any age limit to this expectation, or is it still required for all patients that meet ACS registry inclusion to have a screening? So, for example, would it be expected to complete it on a 2-year-old child? Absolutely not. So really, the way we've set this, or we've expected this criteria to be determined at a trauma center for children under the age of 15 is we don't have a mandatory age for the screening. We have allowed that to be determined by the institution. So the trauma center is going to determine what that age is, and the start age and the cutoff age. So during a site visit, what the reviewers are going to do is they're going to look at your policy, and they're going to ensure that you're adhering to your own policy on that age requirement. In regards to expert, does a full AODA referral count towards a brief intervention? Example, a person has both a positive blood alcohol level and a positive audit C. In such cases, our social workers will provide a full AODA assessment and provide resources. Are they also required to provide a separate brief intervention? If so, do we need to chart the actual words, brief intervention completed, or does any wording which addresses alcohol resources qualify? So I had to Google AODA, and I hope I got this right. So I found it to be the alcohol and other drug abuse assessment will count towards brief intervention. In addition, it will count as the assessment tool. So if you're using that, that is acceptable. And whatever verbiage or language you think is appropriate to document that process, that's also acceptable. So we're going to move on to CME. So a question about if we have an invited speaker, trauma surgeon, trauma-related topics from other state, can we count that as external CME? Since the facility is arranging for the speaker, in this specific example, this would count as internal CME. The only time external CME is going to be appropriate is if it's from a national conference, you're attending a conference or a state region meeting that provides CME, external CME. I'll have a breakdown, I think, at the next webinar that would just break it down a little bit more. Please explain the CME requirement for the subspecialist liaison to the trauma service. Please explain the CME requirement for all other specialty physicians to the trauma service. Are there specific requirements for nursing education in the trauma unit or ICU or step down? So currently we don't have any specific nursing requirements. Ideally, you know, we expect the nurses to be trained in their specific areas. And the one requirement that we currently do have, and again, we're working on this in our revision process, is for the center to ensure that nurses are providing nursing education. So that's CD 17-5. Subspecialty liaisons are required to have a minimum of 48 hours over 3 years. That breaks it down to 16 annually of external trauma-related CME. And for other subspecialists, I know in this slide we're using subspecialists. We kind of referred these to liaisons and non-liaisons in a lot of our other slides. So I just want to clarify that. So other subspecialist surgeons may supplement the CME requirement with either an internal education process credits, which should be equivalent to 16 hours per year, or with internal and or external trauma-related CME, or a combination with all. If using a combination of CME, ensure there is appropriate detailed documentation provided at the time of the site visit. That will make it super easy for the reviewers at the time of the site visit. CME internal education process. Please provide detailed examples, suggestions, and ideas for internal education programs. So this is actually taken right out of the book, and it's covered in all the specialty chapters under the CME subject. So as it says here, acceptable internal education process activities may include presentations or discussions of trauma-related topics in the following settings. So it could be in-service lectures, such as the previous slide about a speaker, educational conferences, meaning that if you had a surgeon or a trauma medical director attended a conference and there was something interesting they found that would be helpful for the trauma center or beneficial to improve your processes, and they brought that back and that was disseminated to the whole entire panel, that is actually an internal education process. Grand round lectures, an internal trauma symposium, or in-house publication and dissemination of information gained from conferences or peer-reviewed publications. Again, there's several ways that the internal education process can be done. It's just not limited to what's printed here. There's various other ways to do it. And we are working with Dr. Dente, who's part of the education committee, and developing some best practices for internal education. So hopefully sometime soon we'll have some examples to provide you guys. Maintenance of certification, CME. So this is a new change. We just brought this on shortly after our March meeting, and I know it's new for a lot of people. So many surgeons utilize the American Board of Surgery Maintenance of Certification CME repository to organize their CME. Is this appropriate for verification of attendance, or do they have to have a certificate? Any assessment done for maintenance of certification can be counted towards a total of 33 hours of external trauma-related CME. With that said, the surgeon must be able to provide a list from the repository, and I don't know what that looks like at this point in time. It could be a report, it could be a list, but it does have to be clear and detailed enough to for the reviewers to determine that it's trauma-related board maintenance of certification, and that the subject is related to trauma. So again, this is new for us, and we are looking at additional possible ways of what this may look like in the form of repository documentation. Again, I just want to clarify what form of documentation do we provide to count for 33 hours. And the previous slide talked about repository. I don't know if that's true for every specialty. It may differ, but if it's for the trauma surgeons that are going to use the 33 hours from his or her board, either preparedness of certification or the initial boards or recertification, there has to be some type of documentation to substantiate the hours. You can't just say they just board certify or they just recertify. We have to have something from the MOC. Prorated. If a faculty member starts in September 2015 after finishing a fellowship, how many CMEs are required for the survey period that runs from 2015 to 2017? Does fellowship count for any of the 2015 CME? So using the example provided, CME would be prorated based on when the surgeon started taking trauma call at the institution. Fellowship training, unfortunately, does not count towards CME. And this is true for any, not necessarily just what's on this slide, but for any trauma centers who have new hires or new fellows that just completed residency, prorating CMEs are going to start from the time they started taking trauma call. And, you know, again, just have that noted in the PRQ, or you can have that noted in a separate document so the reviewers see that information. Level 3 trauma centers, are there currently any criterion deficiencies linked to level 3 trauma centers and annual physician CMEs? Currently, there are not. Again, we are in the revision process, but in the Orange Book, there are no specific CME requirements for level 3 trauma centers. We are nearing the end of our 3-year verification cycle. Up until the last 6 months, we had the same neurosurgeon liaison, and now they have a new neurosurgeon liaison, and they're asking whether or not they need to document the one that's leaving or the new member. As I previously stated, you want to have all data relative to surgeons that are actively taking trauma call at your institution at the time of the site visit. So in this example, we want to have data for the new liaison from the time they started their role as the liaison. Seeing that this was a member of the neurosurgeons panel, they're going to get their CME, they're going to be prorated. So use the internal trauma-related CME and any external that was obtained from the time she started. Do not include the previous neurosurgeon liaison information during the site visit or within the PRQ. So in this instance, you can use a mixture of both because they're new to the service, because, you know, if you don't want to use their internal CME, you can use their external, and it's just going to get prorated based on their new role. Board certification, I just want to bring this up again just for clarification. The 33 hours of CME obtained from either preparing for the boards or taking their initial board certification or recertifying for the boards may be used to meet the CME requirement. This may be used once during the 3-year verification cycle leading up to the site visit. If the provider is double boarded, for example, in general surgery and surgical critical care, only 33 hours of CME will be permitted. They can't use for 33 hours for both boards. Not required to provide a breakdown, but we do need some type of documentation that they took their boards. And that concludes our webinar for today. I want to take this time to say thank you again for supporting our webinars and attending our webinar.
Thank you, Trauma Verification staff, and thank you everyone for attending today's webinar, Trauma Verification's October Q&A Web Conference. If you have any other questions, please contact cotvrc@facs.org. On behalf of Trauma Verification and our presenters, thank you for joining us today and have a great rest of your day.